All right, perfect. All right. Good morning, everyone. I'm Sundip Maru. I'm a vascular surgeon out in Western Massachusetts. And this morning, I'm going to be spending the next 5 hours with you guys. Um, my goal is to cover number one, venous and lymphatics, which has become a bigger part of the exam. We'll talk a little bit about vascular complications in the vascular lab, although everybody now is RPVI, but there's a couple of things that we just want to review, make sure you guys have down before you take the vascular exam. And finally, we will talk about a dialysis access and so forth. That's another big component as well. The thing that we want to focus in on a little bit in the beginning, and I'll spend a fair amount of time, is venous disease, just because there has been a bigger push and movement on the venous side, and there have been a lot more questions on exams about venous disease. So I am going to do a brief intro, and then we will jump into venous disease. The first thing is, standard disclosures. And I'm consultant for Medtronic and the routine kind of stuff. So just a little brief intro, right? Here's the goal. Eye on the prize. You want to get that vascular surgery board certificate. We have redesigned our curriculum over the last year or two, especially during COVID. We revamped everything. We tried to streamline it. It used to be a 3-day course. We've trimmed it down to 2 days. We're doing about 19 topics in 20 hours. And the one thing to kind of glance at as you are taking the written exam is the V-Score curriculum. They have put it out in November of 2019, and I think it's very good. So I think we need to take a look at that. The next part of it is statistics. I'm a numbers kind of guy, so we're here at the qualifier. 2019 was an oddball year. Numbers dropped down a little bit. I think 2020 we're starting to come back, and this is, again, remember, we're in COVID times, so they were being a little bit generous. 88% in 2021. So, about 85 to 90% is the pass rate, somewhere in that range. So it's pretty good. And so I think just by reviewing some of these little slides, doing some questions, I think it'll put you into that range very easily. The qualifying exam is about 300 questions. It's 7 to 8 hours, and it's now back at a computer test center. It's something that, more than anything else, practice sitting down for 7 to 8 hours again. That's gonna be a challenge. For those of you taking this course for research, research are similar. The question length is a lot less. You can do it every 10 years still, but there is the continuous recertification. And I do suggest that people really consider this. It is a good way of doing it, very low key, low stress. If you've done CSAP or VSAP in the past, it is a very similar setup in that you do the questions, you get it wrong, you get to read a little bit about it. They will give you all the information right there, and then you can take it again to pass it. So you sign up for it. It's 40 questions on the latest and most important developments in practice. You got 2 weeks to take it. It's a computer test at home. 80% to pass. You must get 40% right, about 16 questions the first time around. And it's open book, low key. I think this may be a great way to go about things if you're not looking to do all that studying. It's a quite easy, and 2 weeks. more like you need to spend about 2 to 3 hours on an afternoon, and I think you can get through it. So I do enjoy this process a whole lot more personally, but you can make your decisions. The continuous, it's 100% online, open book, it's interactive, makes it good. So part of this is that we want to look at strengthening effective test taking techniques, strategies, apply effective strategies. People are often stressed as they go into it, have some anxiety, anguish. Is it hopeless? No. But we just need to get into it. Just do more and more practice questions, and that'll help you get through it. So what's the biggest difference on the vascular surgery writtens? I think the biggest difference is the critical thinking component. It's a little bit different in the general surgery. More of understanding the concepts. Sure, we can get the concepts, and there are some basic questions, but a lot of it is application of what you know. So they are 2-3-step processes. What's wrong? You get the diagnosis. What can be done? What's your initial action? And in what order are you going to do it? So diagnose, identify, apply, and prioritize. And that's going to help you. So I just want to pop through these last couple of slides, read directions carefully, make sure you are understanding the question perfectly. You will have time to get through the test. You may have time to read the test and go through it a second time, making sure everything is okay. So that's usually what helps, just making sure. Sometimes you'll pick up clues during the exam to help you with other questions. So so that's a little bit about the vascular surgery writtens and the research. This is how I roll. Let's get into it. Let's jump right on in. And so let's start with the management of venous disease. Okay, I'm going to spend a fair amount of time on this. I may even roll just a little bit into my lymphatic time, and then I will make that a little bit more brief, because venous disease is a huge topic. And in all honesty, it may even need to be expanded in future sessions, because there are more and more venous surgeons, venous vascular surgeons out there, and they are separating themselves from the arterial side. So I think it is an important thing to review. Okay, so again, my standard disclosures. Let's look back. Historically, venous disease has been out there forever. We have discussed it way back when. 1550 BCE, we see these tortuous solid with many knots blown up by air. And this was the first time they described varicose veins. 400, we have sort of the correlation between varicose veins and ulcers. And then we come into the Common Era, Da Vinci, some drawings and so forth. Now we move into some of the more recent things, and somehow they've started injecting with hypodermic needles, sclerosing agents, stripping in 1905. Linton first described how to treat venous ulcers, Seldinger technique, and finally we're coming into 56. They first described May Thurner, great board question. We'll get into that a little bit later. 80s, we started using ultrasound to take a look at it. 1999, big year. RFA first introduced, and that's where the revolution, I think, really started. So we're talking about the last 22 years of the minimally invasive way of treating these veins. And so we've got a couple of different devices along the way. There's foam, there's Claravane, a sclera. We've got Venous Seal in 2015. So it has just gone leaps and bounds, and we'll discuss it all just a little bit so that we're familiar with it. But I think that that explosion or expansion over the last 22 years has led us to learn a whole lot more about it, and just by default, a lot more questions on the boards about venous disease. So let's first talk about epidemiology. It's about costing the US about $3 billion a year. And it's almost 2% of our healthcare expenditure. About 30% of the population has it. Venous reflux on ultrasound screening, about 10%, and 6.6% on women. Ulcer disease, it's 1% of the population. It's nearly 500,000 people. It costs 2 million work days per year and causes people to retire early. So let's go into the anatomy a little bit. And again, great questions for the board's anatomy type things. So veins, it holds about 75% of the blood volume. It's organized into two layers. We've got the superficial layer and the deep layer. They have unidirectional valves, low pressure system, 10 to 15 millimeters of mercury, and super thin walled. So it is very, very paper-like when you really get into it, as opposed to arterial, which has that muscular wall in there as well. So the superficial system, thin wall, principal collecting, right? And over here, we go down and we have the great saphenous vein. And then in the back of the calf, we have the small saphenous vein back there. I think that the deep system returns the majority of the blood and has valves that's aided by the calf muscle pump. This is why we have changed our thinking. Back in the day, somebody had a DVT, they'd put them in bed. Now we want them up and walking. That's the thing. So let's talk about the great saphenous vein. Okay, so it's the longest vein in the body, about 3 to 4 millimeters in size. It's got about 6 valves. It's housed between the anterior and posterior compartments. It terminates at the common femoral vein. It has 2 valves at the terminal subterminal area, and 1% is truly duplicated. 14% has an anterior accessory. So next, jumping into the small saphenous vein, which is in the back of the calf, it's more lateral and posterior. It's between the heads of the gastroc and empties into the popliteal. It has about 7 to 10 valves. It's within a fascial compartment again, and I think I have a slide of that again in the future next slides. And 95% of the patients have a thigh continuation. So sometimes it reroutes, it doesn't jump directly into the popliteal, it goes up further. The vein of Giacomini connects the great saphenous and the small saphenous. So the next slide has the picture that I really want to show you guys. This is a great transverse look at the vein on ultrasound. And so you see that it is housed between the 2 fascial compartments, and that helps us identify it. So you've got the great saphenous vein, and you've got the superficial fascia and the deeper fascia, and between that there is the vein, and this is a true anatomic view. The thing that to remember, it almost is, back in the day, it was like they used to call it the eye of the tiger, but if you see it in between there, you're in a good spot. Again, more cross-sectional views, I'm sorry, between the two to try to take a look at that. And then we want to jump into the main communication sites, okay? So where are the superficial and deep systems communicating, all right? So we've got at the saphenofemoral junction, we've got the main thigh perforator is at Hunter's Canal. We have medial calf perforators at the medial malleolus, just below, just above, about 10 centimeters above, and just above the knee. And so a good vascular lab, which has taken me some time to get my vascular lab to try to take a look at it, you want to take a look at it from the floor all the way on up. And a good way to have it measured is from the bottom of the foot on up, and to get measurements so you know where those perforators are, because there are newer ways of treating that, which are quite easy. So let's get into that. And so saphenous vein, again, they have names for them. You don't need to know the names. All right, so perforators should be less than 3.5 millimeters. You define a varicose vein, anything greater than 3 millimeters. Reticular veins are between 1 to 3 millimeters, and anything less than 1 millimeter, you're kind of identifying as a spider telangiectasias, okay? So the pathophys of this, right? We have venous obstruction, we have axial and superficial valves, right? And then we have perforator valves and venous obstruction. So this whole thing can back up just by the venous obstruction causing the valves to back up, and looking at the perforator valves and the axial superficial valves. So this is just one continuous system that can easily back up. All right, so let's talk about chronic venous insufficiency.